Hello. So, good evening, everyone. So, sorry for the delay. There was some technical error from my side. Okay, before beginning it. So, once again, good evening, everyone. We are back for our 1 hour MDS 360-degree session, our live YouTube sessions, which offer every day 8 to 9 p.m. So, today, myself, Dr. Rajul Agarwal, I'm the orthodontic faculty at TABS. Will be discusses the topic diagnosis and treatment planning and orthodontic case, a very important topic from your exam point of view, of course, and in general as well, because without diagnosis a case, be it anything, be it any prosthodontic, you cannot plan a case and you cannot start a case. So what are the important points related, what things you need to look in a case? We'll be discussing those points today in the lecture. So if once again, if anyone has any doubt, very well can write in the comment section. I'll be happy to answer it, or you know where to reach us, where to ask us, and we'll be happy to answer. Just a minute. Okay, so starting with the first, the angle versus the soft tissue paradigm. Angle means Edward H. Angle, who is the, as we have discussed in the previous lecture, is the father of the modern orthodontics, who gave us the edgewise appliance. Okay, so according to him, at his time, paradigm means the, first of all, what is the meaning of paradigm? Paradigm means the thinking prevalent at that time. Okay, sir, can we get these handwritten notes in hard copy? Tooth talks. Yeah, it's little bit difficult here. These notes are available on our eMedicoz app. I don't know how we can provide it through YouTube, but these are available in the form of workbook on the eMedicoz app. So you can very well access these notes from there. Okay. If you want to take my advice as a senior, as the one who has already gone through them, just notes ka collection is not important for you to clear your exam. If you really want to clear it, understanding the topic is very important. Notes are very important to revise. So agar the concept which I taught you today is clear to you, you can very well write it down throughout the lecture, post my 1 hour lecture as well. That will be sufficient. Having a copy, अगर वो है ना लिख के रखोगे तो then only you can, it goes into your mind. Okay, so that's my suggestion to you. Okay, so we have one more student. Okay, good evening to you as well, Hansika. Okay, so thank you for joining. Okay, so my suggestion is, do not get these handwritten notes photocopied. Just write it down with your own hands in a register, and these will stay with you for a lifelong. And as I told you before as well, how do you do your MCQs? Cross it down. जो कॉन्सेप्ट क्लियर है कट करते जाओ उस हैंड रिटन नोट्स को. ओके, सो दैट्स हाउ. अगर 10 पन्ने के 10 पेजेस के नोट्स है, in the end they will revise just 1 page for you to revise a day or week before your exam. Okay, anyhow, that's how I used to study, because everyone, be it the one ranker जो first rank लाएगा, उसके पास भी उतना ही time है, the time which you have. Okay, so how well you utilize that time will be able to decide what you do. Okay, कुछ students होते नहीं, don't study कि भाई, some say I used to study for 18-20 hours, some used to say I just used to study for 4-5 hours, and that was more than sufficient. That's how intelligent student is differentiated from a good student. Okay, anyhow, coming back to the topic. So angle versus the soft tissue paradigm. Paradigm means the thinking which is prevalent at that particular. So angle had a particular thinking, and the soft tissue paradigm is the current thinking or current attitude. Okay, so what angle was a advocate of hard tissue paradigm, that is his primary goal was to have a ideal dental occlusion. Means the teeth should be in maximum intercuspation and there should be an ideal jaw relation. He did not worried about the outcome or the outlook which it have on the facial profile of the patient. Okay, whereas the soft tissue paradigm, the primary goal was to have a normal size soft tissue profile. Okay, now the current thinking, if you have gone certain aligner companies or all that, are advocating non-extraction treatment. Why? Because now they believe, or now we orthodontists have seen that inadvertent extraction is leading to disjoint profile later on in the life. When the soft tissue grows, when there is lip lengthening and all occur, there is drooping which occurs because already aapne at time of 15-20 years when orthodontic treatment you have done all for extraction. At that time you have achieved ideal lip competency, very good, it looks good, but the lip continues to lengthen till the age of 30 years. So what will happen? Okay, there is drooping and all, so there is a aged appearance by the time patient reaches 25 to 30. That's why there is so much advocacy of nowadays non-extraction treatment over extraction. And I'm not saying that there is orthodontists do not do extraction now. We definitely do where it is required, but now again angle completely non-extraction. Then came the philosophy of extraction. Now we are in the era to look at a case as a whole, not at just as the dental tissue, but at the soft tissue profile as well. Celsus also believed in soft tissue profile proportion. No, Celsus was a very this person was even before angle. He just believed that you can align tooth by finger pressure. There was no thinking or paradigm behind soft tissue proportion and all. The first thinking or first thought process behind soft tissue proportion came with the advent of Tweed's philosophy, which I discussed during my lectures on cephalometry. Okay, so slowly now, last time also we discussed soft tissue lines and all that, which I said that they are very important, is because of this one. Okay, so coming back to our differentiation between the hard tissue and the soft tissue paradigm is that the primary goal at that time was to have ideal dental occlusion, that means to have maximum intercuspation. Now the primary goal is to have normal soft tissue profile. Secondary goal is to have ideal jaw relation, that is to have class 1 molar and canine relationship. Now the goal is to have functional occlusion. What do you mean by functional occlusion? Prosthodontics maybe sir also tells us to have functional occlusion. What is a functional occlusion? Functional occlusion basically means, agar I have to cut it short, is to have class 1 canine relation. Now we are not worried about achieving class 1 molar, we are just worried to have class 1 canine relation. Why class 1 canine relationship is important? If anyone can tell me from your prosthodontics, why class 1 canine? Because to have canine guided occlusion, अगर कैनाइन गाइडेड ऑक्लूजन होगी तो इसका मतलब आइडियल ओवरजेट ओवरबाइट है, मतलब इंटीरियर गाइडेंस है टीथ में, मीन्स ideal chewing efficiency. That is the goal of functional occlusion. To cut short, this is the logical sequence. As I said, understanding is more important than just memorizing functional occlusion. What is functional occlusion? Okay, so right now our goal is not to have class 1 molar, our goal is to have class 1 canine, to have a canine guided occlusion. Next, earlier in hard tissue paradigm, our emphasis on diagnosis were through dental cast and cephalogram. We were just worried about cephalometric values. If it's Steiner's value said it is procline, we will do extraction. If it says retrocline, we'll procline it. If it's ideal, we won't do. And thus based on modern analysis. Now our examination is based on the true. It involves having cast and radiographs as well, but more emphasis is paid on facial structures and photographs. Next, the approach, treatment approach was to have an ideal dental and skeletal lesion and assume that a soft tissue will be okay, that it will follow the dental pattern. Okay, next, now our treatment approach is to plan the ideal soft tissue relation and then place the teeth and jaw accordingly to achieve that. That's why the need for orthodontic surgeries and all have increased, so as to have an ideal spatial proportion, okay, so that it balances it. If you remember in my previous lecture on cephalometry, I told you, see how the Tweed analysis, how Tweed achieved or came up to his analysis. It was based on this non-ideal. What he did was he did a retrospective study of his cases, and he observed that the reason for relapse or failure of his cases post treatment or post removal of braces was because of non-ideal facial tissue. How come? Because the muscle pattern is not in harmony with the skeletal basis. What Angle was doing was just expanding the arches, expanding. Remember E arch, ribbon arch. He was just expanding the arches through that. So what will happen when we remove the brackets and the wires? The arches used to get collapsed and relapse because of the improper balance between the muscular forces and the dental tissue. So the aim is to achieve ideal soft tissue relationship and place the teeth in accordance with it. I hope it's clear until now. What is the difference between hard tissue and soft tissue paradigm? If it's clear, then only you will understand the need to have correct diagnostic aids and their significance. Okay. Next comes this diagnostic flowchart. Now this diagnostic flowchart is stripped away, picked up from your textbook of Prophet, 6th edition. Okay, now how it is important? Exam may they tend to eliminate one or two things and they just give you fill in the blanks या जो common AIIMS का pattern है. Okay, so you have to select the option which will be the part of that correct empty box. Anyhow, so when a patient first walks into your operatory, what you need to do? Conduct an interview, means obtain the proper case history, clinical examination, and analyze the treatment records. This all sounds very basic. You must have done your third year में clinics में entry होती है. From that time only case history importance is all fed up anyway. But as the time grows, we grow old, patient load बढ़ता है internship में, we tend to forget this whole thing. Okay, so all of this is fed into a database, and based on this we obtain a problem list. Okay, and some of these will be positive. Supposedly patient has a class 1 canine already present or intercuspation is correct, example. So you have to maintain that during treatment, or his facial profile is already ideal. You don't need to procline the teeth, or you don't need to retract, or so that these positive attributes do not get damaged. Okay, and based on this you obtain a problem list and you get a diagnosis of the case. Okay, in addition to that, if there is a pathology present, cyst is present, dentist is anything, you need to control before starting a treatment. Okay, next the problems are listed, orthodontic problems. If any one of you pursue your post graduation in orthodontics, you have to list for every case your orthodontic problems in a priority order and get a possible solutions. Then discuss it with the patient. If it's an adult patient, if it's a child, patient parent discussion, get a consent and formulate a treatment. Very easy. Mostly in one exam they eliminated this, so students were like problem list to ho gayi, what is the thing which is remaining? Once when this flowchart came up in the exam. Okay, so just be clear. Next thing, so what are the essential diagnostic aids or criteria according to Graeber? नेक्स्ट कंफ्यूजन इस पे होता है, काफ़ी लोग पूछते हैं मुझसे. ओके, सो द इसेंशियल एंड सप्लीमेंटल एड्स. सो फर्स्ट ऑफ ऑल देर इज नो नथिंग सच एज नॉन एसेंशियल एड. अगर इफ इट्स अ नॉन एसेंशियल देन यू डोंट नीड टू स्टडी इट बिकॉज इट्स नॉट रिक्वायर्ड. सो देर इज एसेंशियल एंड सप्लीमेंटल एड्स. गेट दिस doubt clear. Next, what are the essential criteria? So first is obtain a proper case history. Next, examination, clinical examination. Obtain proper study models. Sir, should we study from profit? That's a question which I'm not able to answer correctly. Reason being, for every subject there is a proper standard textbook. For our orthodontics at our graduation level, it's profit. Okay, but the problem is during your graduation year, that is from third year we start our orthodontics. In our time we started from second year. Okay, we never opened it. Now all of a sudden before your exam, if I say start studying from profit, you won't be able to understand a single word from it, or you might be able to understand but you won't be able to answer questions from it. Okay, so at this point of time when the exam is, supposedly I'm taking AIIMS now as the upcoming exam in November, 3 to 4 months before, if you open the textbook of profit, 6th edition is the one. Now last month only the 7th edition has also come. You won't be able to understand, or you won't be able to comprehend it in such a time, short period of time. Okay, so what to do? So my suggestion, not only for orthodontics but for every subject as well, is solve MCQs. Okay, attend lectures. If you are part of our institute or anyone, attend your lectures, solve MCQs as many as you can. I'm not recommending one particular book, solve all of them. Okay, if you are doing dental pulse, do it. If you are part of any test series, just do it. Solve as many MCQs as possible and then go have a retrospective thing. Means जिस क्वेश्चन में डाउट है या जिस क्वेश्चन को यू आर नॉट एबल टू अंडरस्टैंड, ओनली फॉर दैट क्वेश्चन गो एंड रीड दैट टॉपिक. जैसे यू आर नॉट एबल टू अंडरस्टैंड दिस डायग्नोसिस पार्ट, मैंने पढ़ा दिया आपको बिल्कुल, या बायोमैकेनिक्स पार्ट, ऑर्थोडोंटिक्स में सबसे ज़्यादा पेशेंट बच्चों को उसमें दिक्कत आए. ओके, सो for that part only go and read it from the standard textbook, then read it from standard textbook, be it for orthodontics, be it for surgery, anything. Okay, so that's my suggestion, and only that part. Yeah, supposedly you have a problem in understanding one particular question, उस question का reference हमेशा pulse में दे रखा होता है, and they generally give, अगर if it's correct, from a standard textbook and page number. So उसके ऊपर नीचे 2-3 पैराग्राफ read करके, if you find anything important as well, you can very well write it in your notes and add it. Okay, moving ahead. So what are the supplemental aids? So cephalogram, lateral cephalogram is a supplemental diagnostic aid, not an essential diagnostic aid. Next, EMG, hand wrist radiograph to ascertain the appearance of sesamoid bone, endocrine test, diagnostic setup or occlusion. So these are the supplemental aids. Beginning with the clinical evaluation. So first, for an orthodontic patient, oral health, oral hygiene. Next, jaw and occlusal function to assess the mastication, speech, TMD disorders, and lastly the facial and dental appearance. So what I am going to discuss is facial and dental appearance, which is important for a orthodontic case. Oral health, you all know, periodontally and all, that's already covered. Mastication, speech I have already discussed, speech and malocclusion. Mastication, prosthodontic part, and TMD surgical part. Okay, so this is a basic diagnostic clinical evaluation which is done for every patient, irrespective whenever the patient walks into your dental operator. So beginning with the systemic examination of face and dental appearance. So in orthodontics it is divided into 3 parts: macro, mini and micro aesthetics. Okay, again very important, because which of the following is or which of the following is not a part of करके questions you get in your exam. So macro, basically macro means the patient look as a patient as a whole from quite some distance. So what are the points in it? Asymmetry, excessive or deficient facial height, mandibular or maxillary deficiency or excess, and so on. Next, what is mini aesthetics? The relationship of the dental to the dentition to the face. So imagine you walked a little closer to the patient and then you see. In micro, at the microscopic level, that means relationship of the dental teeth with respect to each other. So in mini aesthetics, you have teeth, evaluation of teeth at rest, at smile, gingival display, tooth display, and so on. And mini micro aesthetics, you look at the connector level, gingival embrasure level, gingival height, contour, shape, and all that. How come they are important in orthodontics? So we are going to discuss each of these. First, this was the thing which is important. Okay, so this was part of your last AIIMS exam, May 2025. So beginning with the macro aesthetics, that is first with the frontal examination. So very easy. So there comes the rule of fifths and rule of thirds. Okay, so in horizontal proportion, the face is divided into 5 parts, and in the vertical proportion, the face is divided into 3 parts. So important kya hai? Important hai from where the lines are passing. So in the rules of fifth, the vertical lines are passing through the inner canthus via the base or ala of the nose. Next, inner canthus of the eye. This is the first line. Second, from the outer canthus of the line. And lastly, जो becomes important, but although not been asked, can be asked, from the outer 2/5 of the ear. That is 2/5 width of the ear, not the outermost border of the ear. 2/5 width of the ear. Very, very important. So in a proportionate face, the interpupillary width should be equal to the width of the mouth. So the interpupillary width should be equal to the width of the mouth. So again, another potential MCQ. Next, in the vertical proportion, the face is divided into 3 parts, known as rule of facial thirds, and how to measure it clinically using Will's gauge. So what are the 3 lines? Line passing through the hairline, or cephalometrically it's known as the glabella. Next, to the base of the nose. Next, to the subnasal, and lastly through menton. And the lower 1/3 is further divided into 2 parts, upper 1/3 and lower 2/3. So 1 subnasal to vermilion from the upper lip, and vermilion to the soft tissue menton from the lower lip. So vertical proportion into 3 parts, and lower 1/3 is further divided into 2 parts. Okay, so again, as I said, what is important for your MCQ exam? Rule of fifth में, from where the lines are passing, landmarks, and next these 2 parts. I hope this much is clear. Moving ahead to golden proportion. So one thing which confuses students in golden proportion is that this proportion is always this 1:1.618. Okay, so this is not such. Golden proportion is a relation which can be given to anything when it follows a definite proportionality value. This value can be anything, either it can be 1:1, 1.1, 1.2, 1.1. Okay, so what happened was, facial proportions, and subsequently we'll study this golden proportion ahead as well in today's lecture in proportionate of the teeth. These things follow a definite proportion, and this value can be anything, but except that it should follow a subsequent value. Now this value is different for facial proportion, this value is different for dental proportion, and this all comes under the broader term of golden proportion. Anatomically also our body follows a significant proportionate values. Okay, so we are not concerned about that as such for now. What we are concerned is at the orthodontic level. So how it was given, so it was given illustrated by the drawings of the human body by Leonardo da Vinci. It gives the relation to the width as well as the height of the face. Okay, so it's based on a simple mathematical formula, and it is defined as based on a ratio of 1 ratio 1.618, also known as phi or divine proportion. कहने का मतलब ये है that the width of the face to the height of the face should be in the ratio of 1 ratio 1.618. So supposedly if the width is 10 inches like here given, so the height from head to the bottom is 16.18 inch in an ideal proportion. If the width is 100 inch hypothetical value, so the height will be 161.8 inch. So that is the golden proportion for face width to face height. Similarly, we will have this golden proportion, but the numerical value will be different for dental height, teeth height and width as well, which we're going to study in the upcoming slides. I hope I am clear. So again, I'm saying golden proportion does not mean that all values always this. This value can be anything. Numerical value can differ, but it should be in a proportionate one. Okay, so for height, width to height, it is 1 ratio 1.618. Next, so body form types can be classified into 3 types according to Sheldon. It's ectomorphic, mesomorphic and endomorphic. Ecto is tall and thin physique, mesomorphic is average, endomorphic is short and obese physique. Now, overall shape of the face is of 3 types. It can be long and thin, which is associated with ectomorphic body type, broad and square to be associated with endomorphic, and ovoid is usually seen in meso or endomorphic type. So why it's important, how it becomes important in orthodontic treatment planning. Supposedly, if you know, a long and thin face is normal for an ectomorphic body type. That means you won't expand those arches. So what will happen if in a long and thin face you start to expand the arch? What will happen? The face will become broad and it will ultimately lead to relapse of the case, because there is an imbalance between the soft tissue profile and the dental tissue. So that's why in the first slide I said you have to look at the soft tissue profile or soft tissue balance first and then compare it with the dental hard tissue. Okay, similarly in a broad face, and the body is also broad, the physique is also bulky, you won't start extracting the teeth and collapsing the arches. If you extract the teeth, what will happen? The profile and the cheek will fall back. There is again in disbalance between the soft tissue profile and the dental tissue. Okay, that's why this becomes important. So next time a patient walks into your dental operatory or internship, patient you look at during your internship as well. Tomorrow, this is the thing you should apply for diagnosing the case. Okay, moving ahead, the cephalic index. So it was given by Anders Retzius. That's why kabhi kabar exam mein they ask you with the name of, instead of cephalic index, Retzius index as well. This is an accepted name. That's why here remembering the name becomes important. So it's the ratio between the skull width divided by the skull length into 100. Okay, so from which point to which point you measure. So for namesake, just remember these points. They won't come, they are not important in your cephalometric landmark identification. Just remember, for anteroposterior diameter, it's from glabella to opistocranion, also known as inion, and transverse width is measured from urion. Okay, I hope I am clear until now. So according to the cephalic index, again these values important from your exam. Originally Redzius gave us only these three: dolichocephalic, mesocephalic and brachycephalic. Later on Martin and Seller added these two as well. So again Martin and Seller index, also a name, became popular. So this is the cephalic index and the type of face you can appear. Now again, the cephalic index, it is dolichocephalic. The profile of the facial proportion become oblong. I hope this is clear. Next comes facial index. So it was given by Coleman. Again this name Coleman index became popular. So it is the ratio of facial height by divided by the bizygomatic width into 100. The facial height is from Nasion to Mathion. Now there is a difference in cephalic index. यहाँ पर confusion होती है. Here it is skull width by length. Here it is skull face height by width. So numerator denominator gets changed. So चेंज होते ही आपका ये टेबल पूरा उल्टा हो जाता है एज कंपेयर टू द cephalic इंडेक्स. ओके, सो दिस इज वन वे टू रिमेंबर. अगर आपको cephalic इंडेक्स याद है, यू कैन इजीली रिवर्ट इट एंड गेट योर फेशियल इंडेक्स. जस्ट रिमेंबर वन, न्यूमरेटर डिनोमिनेटर उल्टा करो, हाइट बाय विड्थ, फेशियल गिव्स यू फेशियल इंडेक्स. अगेन this classification was increased by Martin and Seller. It's hyper-uriprosoptive, hyper-leptoprosoptive. Next comes the horizontal lip profile. So based on this we have concave profile. This all of you know, convex profile and straight profile. What becomes important is the lip step. So lip step was given by Corcus. So if you remember a step, a positive step, सीढ़ियाँ जैसी होती है to go up. So positive step is part of concave profile, negative step in straight profile, and marked negative is a part of convex profile. Obviously convex means mandible पीछे है या maxilla आगे, so it becomes marked negative. So again positive is associated with concave. Imagine steps. So this much is easy. Next comes poor man's cephalometric analysis. So again a previous year MCQ. What is poor man's cephalometric analysis? So it is facial soft tissue analysis is known as poor man's cephalometric analysis. How do you check it? How do you measure it? So it is measured by line joining the forehead and soft tissue A, and again from soft tissue N to soft tissue O. Okay, so straight, convex and concave, this much you know. What you don't know is at poor man's cephalometric analysis is, what is it? It is facial soft tissue analysis. So just by, instead of taking a radiograph, just look at the profile of the patient, and this is what we do in your private practice. Just look at the profile and diagnose a case. You don't ask every patient for a lateral cephalogram. Why? Because lateral cephalogram is a supplemental aid. It's not an essential diagnostic aid. Next come this concept of facial divergence. This much is clear, then I'll proceed ahead. So what is facial divergence? So facial divergence was given by Milo-Helbin. So it is obtained by joining a line from forehead to the chin. So first thing first, it is a racial or ethnic characteristic. It is not related to the profile, convexity and concavity, which we have already studied. Okay, so for the same class 1 skeletal base, a patient can have an anterior and a posterior facial divergence as well, because it's a racial or ethnic characteristic. So it is basically looking at it, and it seems that it is similar to looking at just the facial profile, but theoretically this concept is different from facial profile analysis. It is relative, it is just the inclination of the lower face related to the forehead. So how do we diagnose it? So we draw anterior. Okay, so a line from the forehead to the chin is drawn. So anteriorly, if a line is anteriorly facial divergent, if the line drawn from the forehead and chin is inclined anteriorly towards the chin, like this. And posteriorly, if this line from the chin, forehead and chin, if this inclines backward, it is posteriorly facial divergent. If it is forward, it can be anteriorly facial divergent. So that means how it's different, because in facial profile characteristic, if the patient has a concave profile, we say it's a class 3. If it is a convex, it's class 2. If it's straight, we generally say it's class 1. But in facial divergence, a similar class 1 patient can have any of these 3 type of facial divergences. It's not necessary that if there is anterior divergence, it's class 3. If it's posterior, it's class 2. So a similar class 1 skeletal base patient can have any kind of facial divergence, because it's a racial or ethnic characteristic. Now question, sir, Zarabak ratio based on DZ. Sorry, I did not get your question, Komal. DZ, what is DZ? So please elaborate what is DZ, and I'll be able to help you out. DZ. Next comes nasolabial angle. So this is a cephalometric value. Okay, so the angle drawn from the tangent to the lower border of the nose and tip of the upper lip, that is upper lip anterior, range is between 85 to 105 degree. So Zarabak ratio based on this, based on facial divergence? No. Zarabak ratio is a vertical facial proportion. This is just, if you want to understand it more, inclination of the chin. So it's basically a racial or ethnic characteristic. It has nothing to do with the skeletal proportional base. So it can be because of soft tissue or fat deposition as well, because certain racial or ethnic character people have certain kind of facial divergence. Okay, so I'm just mentioning this to make you understand that कि एक facial divergence करके भी term होता है given by Milo-Helbin. Okay, moving ahead. So nasolabial angle, all of you know. So what you don't know and how it becomes clinically important in planning a orthodontic case is, it is drawn from the lower border of the nose to the, so if this nasolabial angle is decreased, that means the upper lip is ahead, that means the upper lip is proclined because of, why upper lip is proclined? Because of proclined upper anteriors. That means you need to retract the upper anterior. That means extraction is wanted. Extraction, distalization, anything. You need to basically retract the upper anteriors. And in this case, if it is obtuse, what you get in your exam is not, sometimes they give you increase, decrease. They can also give it to you as acute and obtuse, which happened I think in NEET 2024. Acute and obtuse. So if it is acute means it is decreased. That means extraction is required. If it is obtuse, like in this case, that means the incisors are either straight or retroclined. you need to upright them or procline them so as to obtain a correct nasolabial. Okay, I hope this is the thing for important for exam. The range and value, of course, becomes secondary important in the current application based scenario exam which is occurring. What is important is this. So decrease or acute. Please do remember this one, acute. Okay, because what student gets confused is अब range to 85 to 105 degree है तो already 80-90 degree acute value ही 90 से कम. So don't take it like that. मैथमेटिकल टर्म में एग्जामिनर का कहने का मतलब है एक्यूटनेस मतलब डिक्रीज होना है, ऑब्ट्यूसनेस मतलब इंक्रीज होना. मैथमेटिकल टर्म्स में आई अंडरस्टैंड 90 से कम सब एक्यूट होता है, 90 से ऊपर ऑब्ट्यूस होता है. ओके, मूविंग अहेड. So increase is seen in patients with retrognathic maxilla or retroclined maxillary incisors. So you need to check the position of the maxilla or the incisors and accordingly do your treatment plan. That's why I said today's class is diagnosing and planning an orthodontic case. Okay, so whoever is in internship tomorrow, this is the thing which you will do different. Okay, my teacher always used to ask me whenever he used to teach us कि what is the thing after today's lecture क्या आप different करोगे, what is the thing, one thing, two thing different you will do in tomorrow when you see your first patient. So I hope today's lecture helps you in that. So इसी concept को अब हम simply we are not studying for your final year exam, we are studying for your entrance exam, PG entrance exam. तो इसी concept को हम extend करते हैं. So imagine a scenario like this. Now as I told you nasolabial angle में angle में क्या होता है, दो लाइन्स होती है. दो लाइन हमें nasolabial में कहाँ मिल रही है, one from the lower border of the nose, second from the lip. अब sometimes supposedly it so happens that the upper lip is upturned. Now if the upper lip is upturned, what will happen? This angle becomes increased or obtuse. Now if this angle becomes obtuse, it will give you an incorrect value. Now the lip is rightly positioned but the upper nose is upturned. So what we'll do, if you diagnose your case and plan your case based on this incorrect value and you start proclining what will happen? The lip will become incompetent. So henceforth, we orthodontists came up with this concept of upper and lower nasolabial angle in cases where the upper lip is upturned, so as to obtain an appropriate solution for our planning. So what we do is we draw a true vertical bisecting the subnasal angle, true vertical, like this, and we obtain upper nasolabial angle and lower nasolabial angle. So after this true vertical, our diagnosis and planning is based on the lower nasolabial angle value. Okay, I hope I'm clear. Moving ahead, the mentolabial sulcus. So what is a mentolabial sulcus? Very easy. Like in the upper we have a nasolabial, now in the lower we have a mentolabial sulcus. So it is the groove between the chin button and the lower lip. So a thin or no sulcus means that a chin button is recessive, while in cases of the prominent chin button, the sulcus is deep. अब chin button prominent है, sulcus becomes deep. Chin button recessive है, sulcus becomes shallow. So chin button recessive means the mandible is also पीछे. Okay, so what will happen? Mandible पीछे, lip is there, upper incisor will hit on this lip. What will happen? The lip will become everted or upturned, like in this photograph, leading to deep mentolabial sulcus. Okay, so in what cases deep mentolabial sulcus can happen? In proclined incisors, means class 2 div 1 cases. नाउ MCQ में जो एक कंफ्यूजन यहाँ से अराइज होता है, सर क्लास 2 div 1 में इट्स बिकॉज ऑफ द प्रोक्लाइंड अपर इंसाइजर हिटिंग ऑन द लोअर लिप लीडिंग टू इट्स इवर्जन एंड डीप मेंटोलेबियल सर्कस, करेक्ट। div 2 में क्यों ऐसा हो रहा है? div 2 में इसलिए हो रहा है बिकॉज द इंसाइजर्स आर रेट्रोक्लाइंड, so because of this there is excessive activity of the mentalis muscle leading to chin becoming more prominent. So class 2 div 1 and div 2 in both cases the mentolabial sulcus is deep, and hyperactive mentalis means a particular term दिया, it's known as golf ball appearance. Okay, if anyone has looked at a golf ball, it has certain dots and depressions present, known as golf ball appearance. I hope mentolabial sulcus concept is clear and no one will ask me कि pulse में सर ये दिया है, because वहाँ पर एक question में I don't know whether they have corrected it until now or not. Deep mentolabial sulcus is present in both class 2 div 1 and div 2. Div 1 is because of proclined incisors leading to eversion of the lips leading to deep mental. Div 2 is because of hyperactive mentalis activity and leading to deep mentolabial sulcus. Why hyperactive mentalis activity? So as to obtain proper lip closure. Moving ahead, sir, it's a case of lip trap also. Now there is a two terms, lip trap and lip biting. So lip trap, yes, correct, because of the proclined incisor the lip becomes trapped behind these incisors. Okay, moving ahead, lip competency. I hope I am clear, lip trap and all that. Moving ahead, lip competency. So there are four kinds of lip: competent, potentially competent, incompetent and everted. So एक चीज और, there is no term as such as potentially incompetent. So please ये doubt मत पूछना what is potentially incompetent. How come it is everted then? Lip trap का मतलब ये नहीं कि वैसे सारे टाइम because of this. So if you can look at my image in the screen, ऐसे करके रखिए. That's why I said कि habits में I explain lip biting and all that. Lip trap का मतलब है because of the proclined incisors वो उसके पीछे फंस गया, but when the relaxed state the lip gets everted. Okay, so if you want कि MCQ terms में, ये तो clinical explanation हो गया, MCQ terms में यह समझना है. So all lip trap cases does not lead to deep mentolabial sulcus, but lip trap is present in all class 2 div 1 cases because of proclined incisors. अगर आपको MCQ टर्म में या आपका कॉन्सेप्ट क्लियर करने में समझना है, आई होप नाउ इट्स क्लियर. बिकॉज ऑफ proclined incisors lip trap is present in class 2 div 1 cases. That too, that does not mean it becomes a universal truth that in all class 2 div 1 cases lip trap will be. It will become depend upon the amount of overjet. Overjet ideally is 2 to 4 mm. अब 5-6 mm या इतना नहीं है. That does not mean कि every class 2 div 1 compensated cases भी होते हैं काफ़ी को, जिसमें lower incisors get proclined. If you remember decompensation and compensation from orthognathic classes. So in compensated cases में lower incisors are sometimes proclined. So overjet इतना नहीं होता, but still that's a class 2 div 1 case only. So उन cases में lip trap नहीं होता काफ़ी बार. So lip trap is present in class 2 div 1 cases, but lip trap does not mean that it will always lead to deep mentolabial sulcus. It may or may not lead to deep mentolabial sulcus because of eversion of the lower. Okay, so that can become a potential assertion reasoning type of question as well for you. Moving towards lip competency, so there are 4 types. potentially incompetent lips करके कुछ नहीं होता. Competent means 0 to 2 mm gap. Potentially competent means there is lip gap between the lip because of proclined incisors. So if you correct those incisor position, the competency will improve. That's the need for extraction cases. Incompetent is due to short upper lip. So howsoever retraction you do, howsoever proclination of incisors you will correct, the lip competency won't be achieved. So in those cases you have to increase the lip length. So उसमें आता है हमारा दिस ऑप्शन लाइक बोटॉक्स जो आजकल पॉपुलर हो गए हैं, या लिप लेंथनिंग सर्जरीज जो पेरियो में करते हैं. ओके, मसल रिलैक्सेंट्स इंजेक्ट करना. ओके, मूविंग हेड, इवर्टेड लिप्स नोन एज आउटवर्ड टर्न लिप्स. Coming next to the mini aesthetic or tooth lip relationship analysis. So we have done with macro aesthetics, we are left with mini and micro aesthetics. Mini aesthetics में सबसे पहले ये आता है टेबल which is very very important. अभी last 20 May 2025 में was part of your AIIMS May 2025 exam. Pitch, yaw and roll. Okay, so what is important in this is pitch, yaw and roll. So how does this concept came? This concept came from the aerodynamics concept. Abhi recently this Air India crash mein they are expecting this pitch. If someone has read this preliminary report, they are trying to understand the wind pattern and the effect on this on that aircraft, why it was going up. If you read about the initial report which is in the circulating in the media, I don't know how much truth is there in that report. But this concept of pitch, yaw and roll is from the concept of flights and aerodynamics, which was included or extended into this concept in our orthodontics. So what is it? So pitch, yaw and roll, इसमें important है आपका दो चीज़ें, the plane and the axis. So yaw means the plane is axial, axis is vertical. So this vertical axis, and the rotation is along the axial plane, that is up and down. So rotation of jaw dentition to right and left side around the vertical rise gives rise to midline discrepancies. Example, class 3 malocclusion with posterior crest bite on one side and scissor bite on other side. इसका सबसे clear example is if you look at the image of Tom Cruise, उसका yaw में problem है, his one side is deviated from the other. Next is pitch. The plane is sagittal, the axis is transverse, that is up and down deviation. And how do you evaluate it? Using clinically and from cephalograms. Example is if you want to look Akshay Kumar, because when you look at him smiling, there is excess amount of gingival display. So there is a problem, might be a problem that his maxilla is down in front. Roll is coronal or anterior posterior, that is vertical positioning of the teeth, that is different positioning on right and left side, up and down deviation around a transverse axis. I hope this is clear. So in mini aesthetics you have smile analysis, in which you evaluate the transverse cant of the occlusal plane or roll of the aesthetic line. So a dentist can detect, again a very potential important MCQ, 1 mm deviation from side to side, whereas a lay person detect it at 2 to 3 mm, and in degrees it is 3 to 4 degrees. What I mean to say is, अगर एक dentist होगा तो he can see even a 1 mm deviation as well, whereas for a lay person it is approximately 2 to 3 mm. So you won't start treating each and every case, you have to look at एक mm पे नहीं, अगर 2 to 3 mm भी है, so it is satisfied. So for an orthodontist there are two types of smile, forced or social smile, that is a voluntary smile. Okay, so if we ask a patient smiles, wide smile, that is a forced smile. So it can be reproducible and can be used in orthodontics diagnosis. Enjoyment or Duchenne smile, it is spontaneous laughter which comes on hearing a joke. Okay, so it is non-reproducible and it is not used for diagnosis. So evaluation of smile may, you need on a forced or social smile, you evaluate the amount of incisor and gingival display. Okay, so the typically in adolescent it should be ideally below, slightly below the gingival margin with approximately 2 mm of coverage. So important line, most or all of the upper incisors can be seen. So ये जो patients आते हैं, if anyone would have seen that our teeth are big, appearing big on smiling. So you need to look with what is the age. If it's a youth or a child, it is normal. You won't start intruding it or retracting it because it will give an aged appearance at early age. Now Hollywood smile is a different thing. It is absence of spacing in the deciduous teeth, is known as Hollywood smile. Ideally, the primary dentition should have spacing between them. If the spacing is absent, it is known as Hollywood smile. So the acceptable range of tooth display or coverage should be 1 to 4 mm of the incisor crown. High smile line means the show of teeth is 2 mm above the gingival line. So it can be due to the following concepts. Purely dental means abnormal eruption. Muscular because of hyperactivity of the muscular elevator muscles. So in that case, what you need to do, muscles में injection देना होता है, botox injections and all that, which is quite nowadays very popular. Anyhow, we are not going to discuss that. Dentoalveolar skeleton due to excessive protuberance or vertical growth of maxilla, known as VME, and dental can be due to excessive overjet and overt bite. And low smile line will be exactly opposite to that. Next is lip line. So अभी तक हमने पढ़ा relationship of the upper lip with respect to teeth. Now we have a relationship of the lower lip with respect to the upper teeth. So ideally the 1 to 2 mm of incisor length, that is the upper incisors, is covered by the lower lip, known as average lip line. Okay, so in class 2 div 1 it is the lip line is lower like this, and div 2 it is higher. Why? Because of retrocline upper incisors, so the lip line becomes higher. Next comes buccal corridor. So buccal corridor is the amount of dark spaces, this which you see. So it is the ratio of intercommissural width divided by the width from first premolar to the first premolar. So this is the intercommissural width divided by width from first premolar to first premolar. So if the buccal corridors are wide, means there is a potential for, there is excess black space in the corners, so we can expand the arches. If the buccal corridor is already narrow, you cannot expand the arches in that space. Okay, again it depends on the case to case as well. You need to evaluate other factors as well, which I have discussed in macro aesthetics. Next comes the inclination of teeth. So teeth can be tipped or inclined left or right as well. Okay, so up to 2 mm deviation is normal. Okay, just remember this rule of 2. More than 2, a lay person can also diagnose it. So in borderline cases, broad faces, expansion. In narrow faces, you need to go for extraction. A narrow face, you cannot, as I've told you cannot expand the arches. You need to extract it to keep the arches narrow. Next comes the smile arc. What is smile arc? It is the contour or the incisal edges with respect to the lower lip, curvature of the lower lip. So if it follows the lower lip, it is known as consonant. If it does not follow, it is a non-consonant. So it is of two types. It can be flat or reverse. Flat means if the incisal edges are flat and the lower lip is like this, or it can be reverse as well. So the incisal edges are like this and like this. So the contour is opposite, or it can be flat as well. Next, smile index and Morley's ratio. Again, PYQ, Morley's ratio. Those who have undergone the PYQ lecture would have seen this. Smile index It was given by Ackerman and Profit. It is the ratio of intercommissural width by the interlabial gap. Buccal corridor is intercommissural width by the premolar width. So smile index is increased in situation where there is decrease in incisor show is present. Okay, and vice versa, because of, look at the numerator and denominator. Morley's ratio is the percentage of incisor show on smile with respect to clinical crown height. Average value 75 to 100%. Okay, so these values again I am saying are very important. Smile index, Morley's ratio, कौन numerator में denominator में, just go. Again comes the now last thing, microaesthetics, that is the relationship of teeth with respect to each other, that is the tooth proportions. Now here again comes the golden proportion which I told you in the beginning of the lecture. So like the same kind of proportion in the face width by face height, 1:1.618, we have a similar kind of relationship between the mesiodistal width of the tooth and the height. So in height width relationship, the should not be greater than 80% of its height. So important to note that we need to evaluate the possible causes. It can be due to incomplete eruption, attrition, excessive gingival height, or distortion of the crown form. Similarly, there is a width relationship of the anterior teeth to the actual mesiodistal width. So because of the curvature of the arch curves back. So you have a apparent width and the actual width. So the apparent width is 62% of the actual width of the neighboring teeth. Okay, this all becomes important when you used to do teeth setting in your second year and third year and final year, complete denture teeth setting. If you remember, wax में करते थे, you need to angulated glass plate relationship and all that. Okay, so this is also follows a proportionate value known as golden proportion. So the apparent width golden proportion and the height width relationship of the teeth. Next, the connectors and embragures, you all know. So connector width, connector is the contact between the teeth. It decreases from anterior to posterior and moves apically as the teeth progresses. Therefore, it is maximum between the central incisor, and embragure is the empty space here located here. That is a back triangle due to short interdental papilla, and this generally it is filled with the papilla. It can be lost or recede due to gingival tissue related periodontal disease of crowding and rotated teeth. Gingival height, shape and contour, I am rushing through them because these are all part of your periodontal diagnosis, which would have already been covered in much greater detail in the peri lecture. So height, the central incisor has the highest level of height, lateral has a lower level, and canine at the level of central incisor. So this is the gingival height. So it is how it becomes important in orthodontics is in case of tooth substitution. Supposedly the canine needs to be substituted in place of lateral incisor, so you need to look at the gingival height as well. वो lateral canine लिखना चाहिए lateral की तरह ना, does not mean just closing the space around that. Next is shape of the gingival, means curvature of gingiva at the tooth margin. So in the canine and central incisor, it is elliptical shape with zenith distal to the long axis, and in lateral incisor, it is half oval or half circle with zenith lying along the long axis. So what is a zenith? This tip. So in central incisor and canine, it is distal like this, whereas in lateral it is like this. Okay, so a normal ideal intercanthal distance is 30 to 35 mm. I hope it is clear. If anyone has doubt, can write in the comment section. Otherwise, I'll end the session. Already we are 10 minutes past the time. Doubt related to any topic of orthodontics, I'll be, sir, where can we reach you out for you for ortho doubts. You can write it in the comment section, or we have a WhatsApp group as well, Facebook club as well, DAMS MDS Press Club. You can mention your doubts. You can message me on the Facebook as well. मेरा प्रोफाइल शायद रिजुल अग्रवाल नाम से ही है. You can message me on Messenger. I'll be very happy to answer. There's no need that you need to be a student of DAMS to get your doubt answered. I do not believe them. I'll be very happy to help you out with any of your orthodontic doubts. Just for lectures and all that, you need to ask the admin team there. Okay. Any doubt related to orthodontics, anytime, you can message me on the Facebook club. I'll be happy to answer. Facebook club, personal message on the Messenger, please, anytime. No need for that. थोड़ा सा डिले हो सकता है आंसर करने में, बिकॉज मैं थोड़ा सोशल मीडिया कम खोलता हूँ. ठीक है, सो डोंट टेक इट एज ऑफेंस दैट आई एम नॉट आंसरिंग. जैसे ही मैं ओपन करूँगा आई हैप्पी टू आंसर. नो नीड फॉर, ओके, नो नीड फॉर एनी हेजिटेशन, नो नीड फॉर कि ये तो पढ़ाया नहीं है पढ़ाया. ओके, howsoever I can help, I'll definitely help. Okay, thank you for your time. I'll end the session.